At this point, I'd like to introduce to you Ken Davis, our CEO and President himself, a visionary who's going to make a few remarks and introduce our first speaker. Thank you.
Well, thank you, Dennis, and good morning, everybody. I, too, want to thank Scott Friedman and Anatine and Jeff, Rama, and Eileen Solomon, all our friends who have been so instrumental in putting this together. All of us who deliver healthcare know that we're going through an extraordinary time of transformation. I can think of no better way to start this conference than to have Nirav Shah make a few remarks about where healthcare is going in New York State. But it's not just New York State, it's the country. We have seen in the last few years, and we will see in the next few years, the greatest changes that certainly have happened in medicine in the last 50 years, if not longer. As we move away from a fee-for-service system of medicine more toward population management, taking care of large groups of patients, bundled payments, and shared savings, we're going to see medicine in a way that it has never been before, and in a way that for the first time aligns payers, patients, and providers, all with the same incentives. Dr. Shah has been instrumental in leading this charge in New York State and leading the charge for improved access, higher quality, and greater efficiency. All the things that our healthcare system has to have for it to be what we need it to be over the next 50 years. So it's my pleasure to introduce Dr. Shah, and we look forward to his remarks.
Good morning, everyone. Good morning, everyone. Okay, you've had your coffee. It's great to be here. I am excited to start off this meeting about collaboration, and I can't wait to hear the next few speakers, so I'm going to try to keep my remarks pretty brief. You know, I just wanted to start by giving you a very thoughtful, pithy statement that we have today a perfectly designed $2.7 trillion healthcare delivery system. It is perfectly designed to deliver more and more healthcare. It's not necessarily designed to deliver more and more health, which is what we need. And as researchers, we've almost become a victim of our own success. We come out with great new drugs, great new devices, new treatments, and the treadmill of costs just keeps getting faster and faster. We can't keep up. And part of it is that we're only thinking in our own silos. A lot of the problem happens because we don't get translational in our thinking. We haven't gotten to T3, T4 translation. We haven't figured out how to get the final delivery of all this vast improvement to the patient. A study in the 90s showed that it took 17 years for research to get out into practice. By the time it got into the textbooks and Harrison's, only then did it really make its way into everyday practice and grand rounds and other places. And unfortunately, even though we live in a digital age with Twitter and with a lot of things moving a lot faster, research doesn't make it out there as fast as it should, and it still takes over a decade, even today, for the fruits of what you do to get out there. One of the things that we need to work on together is how to speed up that process and improve collaboration across different fields that will allow us to have patients see those benefits in real time. When you bring a social worker and a health services researcher and a basic scientist and a preclinical researcher and a physician together, suddenly you get ways to look at a problem from multiple perspectives and ultimately the patient's perspective to get them the benefits of it. We're doing a lot in New York to sponsor that. Today, New York has 7 of the 62 CTSAs in the country, and we're very proud to augment those funds with state dollars, your taxpayer dollars, in the form of eCRIP, which is another $17 million, to try to force team science to happen faster and better. And as a result, we keep getting more center grants. We keep doing well competitively nationally, but there's a lot more to be done. I want to give you a few examples of collaboration, and I think I'll end with research, but we've learned that in healthcare, collaboration works whether it's in politics, whether it's in the delivery of care, whether in almost every area you look. In 2011, when we started, we knew we needed to radically transform our healthcare delivery system in the state of New York, starting with our Medicaid program, which was growing at 13% every year, crowding out everything else in the budget. And so what did we do? We didn't come up with the ideas on our own. We collaborated. We got over 4,000 ideas on how to fix Medicaid from across the state. We voted on them. We figured out the best ones. And it was hard. It was much easier if we just said, let's do an across-the-board reduction for everyone. And we did do that too. But we also did some of the hard work. We took the deep dives. And as a result, we saved over $4.6 billion our first year in Medicaid and are on track to save $34 billion. Now that $34 billion represents just a fraction of the 30% that's wasted every year in our healthcare delivery system. Today, 18% of our GDP goes toward healthcare, and a third of that is wasted. Wouldn't it be nice if we had another $1 trillion for research? Well, we could start to get there if we start saving the money and reinvesting it in areas where we know we can make a difference. Well, with our Medicaid redesign, that was one example where, despite the politics of New York State, despite hospitals and unions and legislators and advocates all jostling for attention and trying to save their dollar or their piece of the pie, we were able to make it work. It was very hard, but that model worked. And we're seeing that model more and more now in the care of patients. Makes all the difference. There's a 5-50 problem, right? The 5% of patients who are responsible for 50% of costs. Yeah. And by the way, the other cheapest 50% of patients are responsible for 2% of our healthcare costs. So what do you do with these 5% of patients? We know we can't have all the answers. When we're talking about medical readmissions or ambulatory sensitive conditions, what can we do to keep them out of the hospital and keep them healthy in the first place? The answers are not in the four walls of our hospital. And time and again, we've seen examples where you start talking to the patient. You get other providers like patient navigators and community health workers talking to the patients, and you put teams of people around that patient. You hotspot and you put teams around that patient. You can make a big difference. So Mrs. Jones with the problem list of congestive heart failure, asthma, and diabetes is really Mrs. Jones with the problem list of unstable housing and domestic violence and other issues that are actually leading to those readmissions and that we are ill-equipped as doctors, as nurses, to take care of in the hospital, but we need to, and we need to figure out if we are to reduce costs and improve quality and improve outcomes. Collaboration is also vital in hurricane response. Last year, I was supposed to be here, but I had a little hurricane come down the pike and had to cancel at the last minute. But two great stories come from that. One is around dialysis patients. We had a major dialysis provider in Manhattan lose power, and what were we going to do about that? Well, part of the collaboration was to try to pre-dialyze as many people as possible. On Sunday, over 600 people before the storm hit got dialyzed. And as a result, the crisis was averted and people worked together. Competitors came out and said, I'll take your dialysis patients since you've lost power. We'll figure it out together. We'll figure out the transportation of these patients together. And there was no disaster among patients requiring dialysis. Another disaster that was averted happened in one of our special medical needs shelters in Park Slope, where 650 people were boarding in this one armory. These are sick people. These are people who are institutionalized. And yet, they figured out by collaborating together in real time that when they needed kosher meals, someone just tweeted out there and the whole Brooklyn neighborhood came out with kosher meals. when there was a need for infection control. Docs just showed up and started making those big signs on how to keep your hands clean, how to keep the food from spreading diseases. And not a single diarrheal outbreak was observed anywhere in any of the Park Slope over 2 months patients. And time and again, it was collaboration among people who don't usually talk to each other, who don't necessarily work with one another, that saved us in that example. We have many examples today of billion-dollar IPOs, right? What are the last 3 billion-dollar IPOs I can remember? Facebook, Instagram, Twitter, and they're all built around sharing and collaboration. We know that health today, our health, 60% of what determines our health is not our genes, that's 30%. It's not our healthcare delivery system, which is 10%. 60% happens outside by our choices, by our connections. You know, obesity is contagious, right? Among your friends. So we know that we need to figure out how to do this at every level, from the patient level to the research level. And I'm going to leave you with 3 questions. First, actually, let's make that 4 questions that I want you to answer. As you do your work, always ask, how are you actually creating value for patients? Second, what are you doing to make healthcare more affordable? Third, what are you doing to improve population health with your work? And finally, will you please tell me before you go public with your next billion-dollar IPO? Thank you.